Oh, it's right here. I have it right here. It was part of my next thing, was to hand you the clicker. So let's welcome Tracy to the stage. Thank you.
Thanks. So we don't want to delay anything, and I don't want to do anything between your food, because for me, food is a very important thing, and when I get hungry, I get grouchy. So please fill your plates and don't rush through the line. Get everything you want. So thank you very much for asking me to present today about the Enos Park Access to Care Collaborative. My name is Tracy, and I am an associate professor at Southern Illinois University School of Medicine. I'm the director of population health integration for our 66 counties across the state of Illinois where SIU School of Medicine is involved. And a few years ago, I was very fortunate to be asked to be the director of the Enos Park Collaborative program that the two hospitals jointly have funded, and I'll share some more information about that. But in Springfield, we have two competing hospitals, HSHS St. John's and Memorial Medical Center, and they came together in this collaborative effort to address some of the needs of a certain neighborhood, and we're going to share that information with you. So when you ask people about this program, the hospitals will tell you that this program has exceeded their expectations. And then people ask me that question, and I'm like, no, it hasn't exceeded my expectations. I believe that when you set a program up that is directed towards the clients that you're serving and listens to the people that you're working with, these are the expectations you should have of programs like that. And so that's a differing view sometimes, but it's been really exciting. We were recently recognized by the American Hospital Association with the NOVA Award, and this is an award given to 5 hospitals nationwide for collaborative efforts to look beyond physical ailments to address economic and social barriers to care. And I think the importance of that award to me is that it recognizes our hospitals for stepping outside their comfort box. We need to get people to step outside their comfort box to improve the health of our neighborhoods. And that's what excites me about this award for our 2 hospitals. So we had talked about being this about 45 minutes in length. I'm going to try to cut it down to about 25 so we have plenty of questions because we're running just a little bit later than expected. But in that time, I want to review how we got started, because the process of how we got started is how we really became a collaborative, and that's what's key. I also want to look at the details of the Enos Park Access to Care Collaborative, share some of the details with you, look at our evaluation tools, our measures, our outcomes, and then also highlight how the 6 fundamentals of evaluation practice that you heard earlier today are incorporated into that work. So this all started because of a community health needs assessment. Now, a community health needs assessment is an internal revenue service requirement for nonprofit hospitals. It needs to be performed every 3 years. It's usually done individually by hospitals, but that was not the case for us, and that's what started this great process. Every hospital has to define the community they serve and what they will assess. And that has to have input from public health experts and members of the medically underserved, low-income, and minority populations. And that's a big statement. I do want to say that from an outside person looking in sometimes, they often will get people that can speak for those populations, but not often people from the populations themselves at the table. And I think this is one of the things that the 2 hospitals here have done a really good job of, is trying to get individuals that are of certain populations at the table. But I don't see that practiced nationally. And so if you go back to your community, I would really encourage you to work with your hospitals to make sure they're actually listening to people. It's great to have people speaking on behalf of others, but it's so much different when you really listen to the narrative of individuals who are living that life day in, day out. So the community health needs assessment requirements that hospitals must identify all significant health needs in the community. And then they prioritize those needs of what they will address and why. And for each hospital, the priority must develop an implementation strategy with measurable outcomes that's approved by its board. And that entire process has to be well documented and transparent. So usually it's on their hospital website. So how many of you are familiar with the community health needs assessments of your local hospitals? So there's a lot of people in this room that aren't. So even if you're from education, if you're from other service agencies, you need to go look at those hospitals in your area what their community needs assessments say. This is one way that you can start to build that collaborative effort, and that's what's so important. Because hospitals are looking for partners to help them with this process. And why shouldn't you guys be those partners? So the Sangamon County Community Health Needs Assessment was done in 2015 that started this program. And this is for Memorial, St. John's, and then also our public health department came together. And although our hospitals are in competition, and any hospital, there's more than one hospital in one town, they're in competition. It's pretty much the way it is, right? This is one area that should not be competition. Community benefits. Each hospital has to have a community benefits plan. This is where this community health needs assessment comes out of, and that should not be an area of competition. And that's one thing that you can take back to your competing hospitals and have that discussion with them to help to drive some of the directions that they head with those plans. We also were lucky here in Springfield that our county health department, every county health department has to do a needs assessment every 5 years. Now, that doesn't make sense, right? Hospitals are doing it every 3, health departments are doing them every 5, they're assessing the same communities. So we were really lucky. Our health department thought it made sense to consolidate the efforts and the costs and do it at the same time as our hospitals. So Sangamon County received special permission from the Illinois Department of Public Health to do their I-Plan along with the hospitals themselves. And this was the first time this had been done in this area, and there are not too many examples of this across the nation, as we have spoke to other hospitals and other health departments doing this type of collaborative work. And so this is really key. So this was all about breaking new ground for us, right? To have our 2 hospitals jointly fund one initiative around community. They decided that they would find one priority, and they would then fund that joint project. They would like to do a really narrow and deep focus in one neighborhood and not a shallower dive in. And part of that is because this was outside their scope. This is outside what they were comfortable with, so they were really fearful of failing large. And that's really where it all started. And so that was really good, though, because we know when we take a narrow, deep dive, we can really get into some of the root causes of problems. Both hospitals decided that the neighborhood they would look at is the Enos neighborhood, Enos Park neighborhood. And one of the reasons for that is it lies between both hospitals. One hospital is on one end, one hospital is on the other end of that neighborhood. And our federally qualified healthcare center lies right across the street. So really when we ask ourselves this question, if we can't make sure that the people in that neighborhood is healthy and has access to healthcare, who am I to walk 10 blocks and tell someone that I can help you get access to care? So it wasn't very logical to not work in a neighborhood that's right next door to us. Also, Enos, when we looked at the data, showed us that residents were affected by poor health and social economic issues. There were some very strong pieces to Enos too for us to start to build a foundation on. They had a great neighborhood association. They had a track record of wanting to look at change and do change. They agreed to be collaborative with us. As we were talking about stakeholders, we first went to the neighborhood association and asked them, are you interested in working with us? So we brought them on base from the very beginning. We were very fortunate to have our partners here at the University of Illinois at Springfield to conduct the focus groups for us on access to care. And we also have another great partner through Jorge Villegas here at UIS who helps to support a lot of our data assessment that goes on in this program. What we found after doing this access to care survey, we found that people needed someone to listen to them to listen to where they were at in their life. And so when you go to the literature and you look at who does that, community health workers, the community health worker model does that. So we decided this might be an effective process. They then asked SIU Center for Family Medicine to create a community health worker program. And that's where I came into the picture. So if you wanted this depicted kind of in a visual context, this is what it is. I'm a very visual person. So over here you can see we did our community surveys, the advisory committee had the core group, and then that led to 100+ community issues being identified through that needs assessment. They then looked and examined 22 of those issues, selected 9 priority areas, Came up with 3 to 4 final, and then came up with their one joint one, which was the access to care. So there was a large process to that. This is what that looked like. So for both hospitals and the public health department, they chose access to care. You can see they also chose to look at some individually: mental health, obesity, pediatric asthma, child abuse. So there was other programs that were also built to address those issues, but they weren't jointly funded. Now, most of you probably know about the social determinants of health, but the rest of what I say doesn't make sense if you don't. So just really quickly, I want to touch base on this. So you can imagine what our hospitals wanted to measure, right? They wanted to measure health outcomes: the mortality, the morbidity, the life expectancy, etc. What I continuously said was we can measure those, but we can't get to any measurable change if we don't address all these other social determinants of health in here, right? All the economic stability, the neighborhood and physical environment, the education, the food, all of those things. So this is how the Enos Park Access to Health project is built, is really using this type of model. And the reason this is important is because we know that only 20% of what we do in the clinical care environment is what affects a person's outcome. It's the other 80% that has an impact. And we have to address that 80% for our 20% to even be effective. So I'm going to go through these next slides really quickly because Paula Gramley from Memorial is going to speak around 3 o'clock today, and she's going to go through some more detail about this type of stuff. But we really used data as we started to build this program. We knew that place matters, and we had to start with a large scale to explain this to many of our partners and to many of the individuals who are coming to have a seat at the table because they hadn't really thought about this process before, right? So we know that where you live affects your life expectancy. And you can see from this graph, there's a significant difference depending on where you live at. We also know that zip code matters. So we looked at zip code data, and I'll show that later around Enos neighborhood. But you can see that where you actually live also influences your health, where your zip code is. So you can see in Chicago, very short distances there, you can have over 12 years of life expectancy difference. And also your community matters. So again, you can see here, homicide rate varies per community. Now this is nothing like, woo, I didn't know that, right? But when we bring the data to the table, it helps a lot of people to be able to focus a little bit different in some of the conversations we have. And we also know that food matters. So again, these are those social determinants of health concepts. But I think this cartoon says it really well. So the little people in the car over here say, with all this health care around, why are we so unhealthy? And I think that's just a reality question. And this is a question we can ask in most of our communities that we live in. For us in Springfield, we have wonderful service agencies. We have wonderful hospital systems here. We have wonderful healthcare services. But we also have wonderful horseshoes, right? I love me some horseshoe. We have other wonderful things that don't necessarily support our health. So we are a community that has a lot of things affecting our health outcomes. So let's look at our place. So when we looked at our Sangamon County Social Needs Index, and that's where we're at, we're in Sangamon County here, and we looked at zip codes, we found that there are 3 basic zip codes, 62701, 702, and 703, that has about 34% of the county's population that lives in it, and about 58% of Springfield's population in it. And we looked at those, they ranked worse on our index of health, those 3 zip codes. So we did a deeper dive into those 3 zip codes. And this is an example of how you can do that deeper dive. And Paula later will show you how to get to a lot more data like this. But for instance, when we dive into the 703 zip code, we can see that 72.9% of the households there are single parents versus 40.9% average in Sangamon. So we can start to pull this type of data together, and we pulled this data for those areas that are in Enos. So you can start to see how that zip code makes a difference. But with all that information, what we need to really remember is that there are places and cities around the country that are very poor. but they still benefit from community gardens, active religious organizations, and nice parks. And the people who live in those places are likelier to be healthier, live life expectancy, and have a better capacity to survive a crisis than other neighborhoods who are comparably as poor but don't have those social infrastructures. So when you look at that, that drove us of how we built the Enos Park program. We didn't infuse a ton of money into the neighborhood. We did not have a lot of money to build homes, to build recreation centers, to provide everybody in Enos neighborhood with all the food they would ever need in life. We couldn't create enough jobs for everyone, but what we could help do is build an infrastructure that leads to health. And we had to address those social determinants of health in the process, because this quote tells us that's exactly what has to be occurring. So let's kind of look at the data and think about this. So this is 3 neighborhoods. You can see they kind of run into each other. Enos is where we worked at, and there's about 2,500 residents there. They have a median income of about $18,600. You can compare that to Pillsbury, which is right next door, with about 2,000 individuals, has a median income of about $26,000. And then Pioneer Park, which is a little bit down from there, has about 1,000 residents with $16,000 average income. Now, I want to see a show of hands. Which one of those 3 neighborhoods from this information up here would you expect to have the highest home value? Who would have homes that were rated to have the highest home value to them? How many of you guys say it's Enos? How many Pillsbury? Okay, so the majority. Pioneer Park? So, my caution to you is not to just use one piece of data to build your programs on. There's a lot more that goes into understanding a community than looking at the data itself. And there's a lot of reasons behind this, and I can always talk with you more about that at some other point. We also can look at service agencies in the area. So we plotted out different agencies in the area. This is not a complete map of that, but what you can see is that in Enos Park, there's a lot of service agencies right in that general location. But you get to Pillsbury and Pioneer, it becomes very scarce. So that's also very key as we started to look at evaluation, and we started to look at what kind of programs do we want to put in place, or do we need to help build. So again, just kind of giving you a visual depiction of what we did. Decided on access to care, took a very organizational approach to it that was place-based, that was very community-driven, and I'm going to talk about how the community drove us right away, and then the collective impact process. So Enos Park neighborhood, this is the Enos Park neighborhood. On the one side is one hospital, on the A Street side is another hospital, and at the bottom is where the Family Medicine Center lies. So you can see it is really flanked by healthcare services. But when we looked at the data, we saw that diabetes, hypertension, mental health, and pediatric asthma were struggles in the area. There was a lot of unnecessary ED visits related to that, inpatient stays. Very few people had a primary care provider that they could identify. And we know that that is one of the biggest things when you look at evidence for improved health outcomes. If someone can say, this is my doctor, and this is who I trust, and we didn't have that, and we live right across the street from them, that's a problem. You don't know your neighbors. So taking those 6 elements we talked about earlier, this is how we laid out our process for the Enos Park Access Project. So really, when they were talking earlier about understanding, we set a common agenda. We wanted to do that narrow, deeper dive. We wanted to look for a proof of concept process. We wanted to be collaborative in nature, and we wanted to have measurable outcomes. For the quality logic approaches, I really look at this as our common progress measures. So as a hospital funding this, right away, right, they want to put at the top, increased number of people with a medical home, reduced ED visits for non-emergent health issues. But maybe at the top of their mind wasn't necessarily improved self-sufficiency for program participants. So we had a lot of conversation about that. And we know that that is really important if we're ever going to see those other 2 things change also. We wanted to also increase access to children's mental health services. This came because of a funder's need, right? And also because of some of the other things that we were identifying as problems in our community health needs assessment. So all those things that were discussed earlier by our presenters about these progress measures and what goes into why they're chosen and why, this kind of explains some of those differing things. Now we have a lot more measures that we have, but just these were some examples. Our stakeholders, we really wanted to have a mutually reinforcing activity. So we set up a provider council and an advisory council. Our provider council is made up of agencies in the area that touch anyone who lives in the neighborhood, and we meet with them regularly and send them updates or provide new trainings. Our advisory council is our residents. And what's really exciting, this started out as kind of a separate meeting, and over the time, the Neighborhood Association has brought it in as one of their subcommittees. So it is now a sustainable committee council that will go on with that neighborhood association. And so people come to the neighborhood association meeting and they join the advisory council basically for this program. So this is very oriented towards what the customer is wanting. A summer enrichment program. This is really unusual for a healthcare institution to start out of a program like this, but this is where the community drove it. So we went to meetings and we talked about healthcare. And finally someone raised their hand and said, healthcare, yeah. What I care about is my kids. They're getting into things in the summer. I don't know if they're safe. I want things for my kids to do here. And we brought up all the other great activities that are here in Springfield for kids to do, but there was issues with those, right? So maybe the time wasn't right, transportation was an issue, cost was an issue. They said, we want our own neighborhood summer program. So that's what we created first. Now that was a big step away from what the original thoughts were going in, but because of doing that, that built the trust in the community, and it led to many of the other things that we do now. Our community health worker, we have just one summer community health worker who's hired who runs that program. She lives in the neighborhood. Her kids are in the program. Her husband helps with the program. She helps with the program. So this is really community driven. And then we set up the community health worker program. And then use. This is very critical. So making sure that we communicate back to the community, to the neighborhood, to the funders, to everyone that's around, and then also making sure that we're communicating back to our backbone organizations, especially our hospitals, making sure their staff, their faculty, their board, all those folks are aware of the work that's going on. But as we met with neighbors, what constantly came up is they said, just listen to me. And this quote itself is really what I live by. It says, I think one of the best feelings in the world is when someone remembers something you said. Whether it was something from yesterday, a week ago, a month ago, it's just like, wow, you actually listened to me. And in the needs assessment, what came up time and time again is nobody listens to me. I don't trust the healthcare system. I don't trust the school system. I don't trust the police system. I just don't trust. Or, you really don't know what it's like to be in my shoes. It's because we don't listen half the time. And so we really keep this, I have this posted on my desk, and it's all about listening to others. And so people always say, what would you say your expert field is? I am not an expert evaluator. I am not an expert nurse. I'm really not an expert in much of anything in life except authentic relationships. And that's what I consider myself an expert in. All the other things, I have a lot to learn. But I really do feel that I can have an authentic relationship with someone because I'm a good listener. And I think that's key as we look at developing evaluations and dealing with other folks that we're trying to work with. So our strategy was built on 5 basic fundamental concepts. By concentrating on listening to the stories of our residents, developing genuine relationships, and going to the people, the community health workers allowed us to develop new stakeholders in the process. We were able to empower people who never had made it to the table before, and I think that's what's important. Because we listened, our program, like I said, was developed on 5 basic fundamental concepts. Those concepts are trauma-informed care. We found out there was a ton of trauma in our community that is never being addressed. And we only sometimes re-traumatizing people continuously by the way our systems are set up. We took a harm reduction method. Most people are familiar with the harm reduction method of giving clean needles out and needle exchange programs so that you don't create more instances of HIV, hepatitis, those types of things. But our harm reduction method was a little bit different. It's the same process, which it really means is we don't force someone to make change until they're ready for change. So an example of what we've done in the Enos neighborhood is we had an individual who could not be housed. They were a chronic alcoholic. They had been removed from most housing institutions in the area. He was homeless. He was going to the ED all the time because he was beat up. We worked with the neighborhood association to take a vacant home. They were able to fix it up. We were able to rent it to this individual. We wrapped our services around him. 2 years into the program, he continued to drink. We checked on him every day for just 2 minutes to drop in, make sure he had nutrients, make sure he's getting food. He had his beer, but he was safe. And 2 years into the program, he goes, this is the first time I've never been concerned about being kicked out of my house. I'm ready to get sober. He's now been sober for 2 years, and he's reunited with his family. Nothing we did was rocket science, but we listened to him. And what he wanted was someone to believe in him enough so he could believe back in himself. We use motivational interviewing. So when we talk with patients, and if we're looking at their smoking, we never say to them, well, you need to stop smoking. Why are you smoking 10 cigarettes? Instead, I'll say to them, why aren't you smoking 20 cigarettes? You're only smoking 10. That's pretty cool, dude. And they'll be like, oh, okay. So I'm like, what's keeping you from smoking 10 more in a day? And they identify their strengths for me that way. I don't tell them what their strengths are. Maybe it's cost. They said, well, it costs too much. What else is costing you too much? How do we work through that process? So it's a whole different way of addressing things using motivational interviewing process. We also focused on accompaniment. We know that so many times people are isolated, and isolated is one of the worst things for a person's health. So our community health workers provide a lot of accompaniment for patients, and it's all about building trust. If we don't trust, we don't listen, we don't change, and we can't do anything. We get stuck in a rut. So this, again, is kind of a depiction of what our core concepts are. So community health workers, they're a trusted member who is a liaison, a link, or an intermediary. They build individual and community capacity by doing outreach, community education, informal counseling, social support, and advocacy. The community health workers that work with me can tell you what these pictures mean. They don't just see a fence, or they don't just see a park. They just don't see a building or a housing authority site. They can tell you the stories behind these pictures. And that's what is real. And until you can get to that process with your community, it's very hard to evaluate what's going on in a community. So the community health workers focused on some general things that I've already talked mostly about. The big thing for us, we knew we were trusted when they started to self-refer themselves. They referred their neighbor. As soon as someone moves in, hey, you got to talk to such and such. And again, it's the physical spaces and organizations that shape the way we interact. And when it's robust, we're much more likely to engage one another and build relationships. When it's not, we're much more likely to hunker down and be on our own. This leads to isolation, which I've already told you is one of our biggest problems. So the interventions were threefold. Community, build a community. We're focused on individuals, build individuals. But most of all, we need to look at our healthcare system. We needed to build a system that was worthy of being trusted. Instead of me putting the ownership on the patient saying, you should trust me. So every day when I walk out of my office, I say, what did I do today to deserve my patient's trust? And when you ask yourself that question, sometimes you have to reflect on some really hard concepts. So you can see the other things here that we built for access to care, including the healthcare system. Our outcomes, we measured things such as things we had increased, which we had not expected, or, I had expected it, but that's just me. Employment, income, food, nutrition, healthcare, life skills, mobility, community involvement. We also saw decreases in healthcare cost, unnecessary emergency to visit, recidivism rates, homelessness, police calls, no shows to doctor's appointments. So I had some basic ground rules for our evaluation process when we started. We had to be able to measure self-sufficiency. We were lucky enough in our community here to have a wonderful agency who runs our Service Point, which is a HUD platform for measuring self-service measures, and we use that for a lot of our measurements. We had to be able to measure medication utilization, so being able to get that data from the hospitals was a big step. And then once I got the data, it all had to be also put into a format that we could understand and that we could also bring together and integrate from different sites. Client perceptions, we wanted to have qualitative and quantitative data, so we had qualitative data, and we used a survey that's the CPCQ. It's called the Client Perceptions of Coordination Questionnaire. And I don't know if there was no rocket science to using it. I'd seen it, I liked it, the questions got to what we wanted to, so we chose it to use. But most of all, we had to be flexible. We didn't count on measuring our effect on homelessness when we started out. We didn't plan on looking at our effect on police calls to a neighborhood, but we listened to the community and they told us that's what mattered, so we built that into our program. So being flexible was important. And then transparency. So every month we present how that's going to the neighborhood association. We do quarterly reports. We do year impact statements out. And we had to avoid evaluation fatigue. There's nothing worse than evaluation fatigue. I work in a healthcare system, so I have EHR fatigue. So evaluation fatigue can be the death of a lot of our programs, so we have to be very careful with that, but we still need to evaluate what's important. And we shouldn't just collect data just to collect data. We wanted to make sure whatever we were collecting, we could start to build a plan with the community. And then we did not want to damage trust. We wanted to limit the information being collected, not lose sight of our goal, be very transparent, and we wanted to limit the expense of our evaluation process. We already kind of talked about that today, because the community really wanted people on the ground doing help, not evaluating. So we had to watch that carefully. So basically, we show up, we don't give up. When we give up, we don't know how close we are to succeeding. And I always say, if plan A didn't work, there's 25 more letters in the alphabet, so stay cool and keep going. You'll find one that eventually works. This is some of how we measure things. So we measure different activities that we do itself, number of clients, total patient visits, time we spent with those patients, who's calling us before they go to the emergency department, and what happens once they call us. That to me is a huge symbol of trust, a huge measurement of trust, right? If I call you before I'm going to go to the emergency department and then I follow what you tell me, that's huge. So we're always striving to reach equity. And the apple represents not only health access, but also self-sufficiency measures for us. So we are a program that's all about equity. We also measure self-sufficiency. So this comes out of Service Point, and this is from what our community health workers enter, and so you can see it. It gives us different domains. It's really a great system for us to measure self-sufficiency. We also look at healthcare utilization. We can do that on an individual basis like this patient, or we can do it on an aggregate program. For instance, this patient used to average 1.14 hospital interventions per month, leading to a cost of about $21,000 a month. The hospital was losing about $12,700 on each one of those at a month for the visits, from what was reimbursed to what was the actual cost. After we intervened, and just in a short 3-month period, you can see that we went down to 0.4, and then after the 30 days, we even went down to 0. So the cost per month went from $21,000 to $3,500, with a decrease in the amount of loss from $12,700 to $2,900, and then down to nothing being lost. That pays for 1 month of my program, and that's one patient. Healthcare utilization, we can aggregate it too, so I can look at 6 patients, their frequency. So for these 6 patients, they went to the emergency room or the inpatient stay for 184 times during those 6 months prior, for a cost of $917,000. We're only reimbursed for $393. So, somewhere not quite $600,000 lost in those 6 months. You can look at here, after we worked with the patient, went to only 7 times in the inpatient, so from 184 down to 7, and went from a cost of $917,000 to a cost of $77,000. So we can pull that data, and that's an important data point for our hospitals. But it's really not about those types of things is what the clients say that matters. And we had a publication that is in the Journal of Ambulatory Care Management that talks about this. And what they said, this was a qualitative study, what came out of it was they say they know the help I need. And these are some of the quotes from that study that we did. The last bullet there, I think, says it all. Getting off the medical card is stressful and it's overwhelming. Not that you want to be dependent on the government for your lifespan, but the transition. Without that kind of help, I think it's very difficult. And so these are some of our partners. When we first started, our list was about 3 or 4, and it's expanded, and I probably need to add some new partners to this, so I apologize if you're a partner in the room and your name's not up here. You are a partner in my heart. Our collaboration still continues. We just completed the 2018 Collaborative Community Health Needs Assessment. Access to care remains a priority. We're going to continue our work in Enos. We're expanding to Pillsbury, which Paula's going to share more information about later. And we may add another neighborhood in 2019. And like I said, Paula Gramley from Memorial Medical Center will share more information soon. So, do we have time for questions? Is there any questions? Sorry, I know I really flew through those.
Yeah, it's a good presentation, and you mentioned at the beginning, like it was IRS requirement to do the community health need assessment, but I think beyond IRS requirement, I think it was part of the Affordable Care Act for hospital to qualify for what you call non-profit status, because since most of the people were covered by Affordable Care Act, so hospital would have got a hard time justifying to be in non-profit status. My question is, how about the other hospitals, not in the state, but in general in the nation? Do you have an idea whether they are doing this kind of work?
Paula, do you have, Paula's from Memorial. He's asking about other hospitals in the nation doing this kind of work, and so Paula's really engrossed in some of the hospitals nationwide.
I am not sure who is taking this type of approach. I think this is a little unusual. I think FQHCs and some of the other organizations are getting into community health work. Hospitals are doing some of this, but some of them are doing it on the basis of their patient load rather than a collaborative approach like this was within a place-based approach with a neighborhood. So I'm not saying there are not others doing this, but this was a little bit different approach that we took.
Yeah, I'm aware of hospitals that are doing partial programs such as home-based medication programs, like UCLA, working with Partners in Care, but this is very unique in its comprehensiveness.
Hi, I'm from Kane County, and I am the executive director of the health department there. And this is our second iteration of working with 5 hospitals doing our community health needs assessment as well. And so it is happening around the country. I think Chicago is doing it now. So it is a beneficial way to assess your community and bring your partners together. And as I said, we have 5 hospitals in our community, which we have been working with the last 2 iterations of our community health needs assessment.
And that's really vital. And how did you guys start your conversation to get to that point? I think this is what's important for groups that aren't doing this, is to hear that, how you get to that process.
Well, unlike you, without a university sitting in the midst, I went to the hospitals, the CEOs of the hospitals, and said, this will probably cost you $200,000 to do. And if we collectively do it, it'll cost us each $20,000 or less. And that always gets the attention of the hospitals cost. So if you think 20,000, 200,000, do the math. And so that was the first conversation, and everybody was on board. Well, it worked out so well. Unlike the university, I chose to look at a contractor to come in and do our, for the same reasons you say, none of us had experienced evaluators, so I used PRC to conduct our surveys, our focus groups, and those kinds of things. And it went so well, it was no problem convincing them the second time, but I expanded. So then I went into my 708 board to bring them on board to contribute to the resources and the support of the community. So.
Yeah, and that's a great resource if you have your 708 board, is to connect into them. So for those of you who aren't doing this type of work, look for boards like that you can really connect into, because they're very interested in this type of work and supporting it. So thanks for sharing. Any other questions? Yes. So I always say that
The question was about scalability
Scalability.
to other neighbors.
Yeah. So as we heard earlier, each place is different. That's why we chose 5 concepts that are scalable to whichever location you go to. If we set very finite details of how a program has to run, it's probably going to fail in the next neighborhood you go into. So yes, we have scaled this model up. We've got a version of it that occurs that's funded by United Way in another neighborhood here in town. We're expanding into the Pillsbury area. We have implemented a program similar to this in the Carbondale area, into Quincy. We're working with the Jacksonville area to scale this. We'll be doing some work in Decatur area. So yes, but as long as we have flexibility in the process, we can expand it. It's bringing the right people around the table to have the conversations for funding. And again, that's where, like she was sharing, there are some very key people that you need to bring to that table. So, but yes, it's sustainable, and it's able to be expanded. That's also why we didn't we don't have a lot of distinct measurements that are set in stone, right? So the service point is something that can be used broadly for measuring. It's used by about 15, Amy, is there like 15 other organizations that use it? So there's about 15 other organizations here in town that use it. So it provides us with flexibility, but it yet allows us to measure and evaluate. So making sure that it wasn't so high fidelity that it was very difficult to replicate. Does that answer your question? Okay. Any other questions? Well, thank you. Oh, is there, okay.
One of the 3 major components you listed that was critical for a community and their health was religious organizations in that community. And I saw you have some that you partner with, and you talk about how loneliness is one of the biggest things. And I know that that's something we've been looking into too. So how do you go about partnering with the religious organizations and getting people into there, because that's where community really exists a lot of times, to bring people out of loneliness?
So we were really lucky. We have a wonderful church that sits in the middle of Enos, and they had a parish nurse. So the parish nurse sent us our first patient. We set up our first office at the same place the parish nurse was. We set it up within the church itself. And then that brought in some patients to the church. We also have our church in that area has a little library, and so we did a pajama day party, and we brought a lot of our patients in. We gave them pajamas, and the church was there, members were there, we read books, we did things like that. So one of the things that the church in the area is we really sit with the churches and ask and look at what their strengths are and where are people struggling. So one of our local churches started a sewing club to address the isolation of many of our individuals. They help to run some of the summer programs that they have. So we look for those opportunities for them to get into the community, get trusted, and then see where that fits good. Does that make sense? But for us, the parish nurse was a huge avenue, and setting our clinic up first in that church made a huge difference. It was a very trusted component of the community. Any other questions? Thank you very much for your time.